Medic 35 for a medical call, 1410 Richmond Parkway, across from Eugene Hyman, key mount 605 entering. Medic 35 for a medical call.
Hello, everyone. Welcome back to the Fort Bend County EMS Training Division podcast. I am your host, Lieutenant Javier De La Rosa, and joining me in the studio today is Deputy Chief Rob Atripaldi, and virtually joining us today, a very special guest, Dr. Mark Escott from Austin-Travis County. Welcome, Dr. Escott.
Thank you. It's a pleasure to be here.
Yeah, it's a pleasure to have you virtually. If you could give us your background and history in EMS, and then we're going to get into something that we're all, I think, really passionate about.
Sure. Well, I started EMS back in 1991 at Cypress Creek EMS and was a volunteer there and a paid paramedic. And I went on to start an EMS service while I was a student at Rice University and stayed on there as the EMS director. Then went off to medical school, came back and became an EMS physician, initially in Hershey, Pennsylvania, and then came back to Texas as the medical director at Rice and associate medical director at Cypress Creek. Then moved on to Montgomery County for a few years and now the city of Austin and Travis County, where I am honored to serve as their medical director. Currently, I'm also serving as the city's public health authority and medical director for public health. So quite busy these days. I
was going to say, you're a pretty busy guy.
Yes, well, it's nonstop action, and I tell you, I think the marriage of EMS and public health for us has been fantastic. It's certainly allowed a lot of flexibility, and we certainly couldn't have done things as well as we have here in Austin without that EMS partnership.
Yeah, that's fantastic. So today, I'm gonna give you the background of how we came to talking about this particular article you wrote back in 2015. We were sitting around, and this is a little bit a couple weeks ago. We're talking about Halloween in our next podcast, and what we wanted to talk about is what scares us as EMS providers. So we kicked around a lot of ideas of motor vehicle accidents, right? Driving and getting in a wreck while you're transporting a patient, needle sticks. And then we said, you know what scares some of us and scares our providers, not just here, I think across the industry, but getting fired for making a clinical error. And I think that was huge. A lot of us were like, yeah, I think our providers here are fearful of that. And that's pretty much across the industry. And then we circled back to an article that you wrote that we push out during our critical care course here internally. And we found your article and we're like, that's our next podcast. So Chief Atripaldi, you're the one that supplied this article to our folks. What made you pick this up and say, hey, this is what we want?
Well, I think historically in EMS, I've come into different training areas and organizations, and I think it's gone one of two ways. One is we've got cookbook medicine, and we ask you to follow step 1, step 2, step 3, step 4. And when you do step 1, step 3, step 2, step 4, then we're going to talk to you about it. And if you continue to do that, we're going to ask you to look for a different line of work outside of our organization. And that's one method that I think historically where EMS has gone. Toe the line, follow the rules, and you'll be fine. And then where we came, probably I would say, from the agenda to the future and really looking at EMS providers as clinicians, we looked at, well, if they're going to be clinicians, then we have to, in essence, train them to understand what they're looking at and not just be able to follow a set of numbers and rules in an orderly fashion. So we had to look at getting some sound anatomy and physiology in their pockets and some pathophysiology and have them have the ability to be flexible in clinical guidelines to look what's in the best interest of the patient based on the presentation. As I've said before in many classes, your patient didn't read your myocardial infarction section of the textbook, so they just present a little differently. And when they do, we need to have sound clinical judgment to be able to work in and out of those kind of patient presentations. And historically, when I came here, I think it's gone both ways. So people just didn't know what to do. Do I follow the rules, or do I have the ability to feel free to think? And so that's where we came into this partnership with Dr. Escott and seeing if we could get something going, as well as see if we could lessen some of the anxiety on our providers.
Yeah, and I think that leads me to my question. Dr. Escott, was there a specific incident or reason that prompted the article, or was this just kind of something you're passionate about? What was the motivation behind it?
Well, it's really a collection of experiences, both as a paramedic myself and as a physician, in observing the differences in how errors are treated in the two different areas. We see physicians who make errors. Sometimes those are consequential because they result in a bad outcome, or because they get sued for it. But it doesn't often result in firing, unless it was grossly negligent or reckless. But what happens is there's a process, a peer review process for identifying where the errors were, both personal errors as well as system errors. And there's a process for mitigating those in the future through education or through system design changes. And it's, part of what I discussed in the article was this concept of EMS or paramedics as a renewable resource. Well, if one doesn't work out, we'll just get another one. But that's not what we want. We want to build people. We want people to understand they're fallible, and we want them to learn from their mistakes so that they're better. And that was really the genesis of writing that article, as well as some of the others in that series.
You wrote the article about 5 years ago now. Like all things in medicine, some of those things are no longer relevant, right? Like I think brutalium is not something that's commonly used anymore, right? Is this theory still relevant?
Absolutely. I think it's more relevant now than ever. As was mentioned before, we're in this process of rediscovering what EMS should be and could be. And that is that transition from that technician mentality to the clinician. We've always thought of EMS as paint by numbers, right? Here's what you're supposed to do. Here's the algorithm, and you have to follow it. And you realize that that's a good way to start in your career, right? You don't know much. You don't know how to interpret things. So it's relatively safe, painting by numbers, going through the algorithm. But eventually you realize that medicine is more freeform. And you've got to use that as the basis for making decisions, but you can't be walled in by that protocol or by that algorithm. And part of the challenge that we've had in EMS is that we've tried to sell that there's not medical decision making happening, because that's only something a physician can do. Well, we all know, you've been in EMS a week, that there is medical decision making. The problem is that if we don't train people to develop differential diagnosis and how to prioritize that differential diagnosis, it leads to errors. So it's not preventing errors, it's leading to errors. And that's probably the most common thing that I've seen in errors, in my systems, and certainly as an individual who participates as an expert witness in EMS malpractice cases. I see that over and over and over again. The failure to identify alternate diagnoses and prioritize other things which were probably more likely.
Chief, did you want to follow up?
Yeah, I think it's what he just said was super important. We're talking about differential diagnosis, the possible versus the probable, and you say, well, I'd even add a third, what the heading is on the protocol, shortness of breath. Then there's a possible diagnosis, and then there's a probable diagnosis, and between those three things is a huge gap in our educational model. how we teach our paramedics and how we circle back around and re-educate them, and how we get them to have clinical thought processes as opposed to just it's shortness of breath, and that gets this mixed bag of drugs and this technical skill set. It's almost more difficult, Doc, at this point in time. Easy for you or me to walk into a paramedic class and give them that information and have them start to think out of the box from day one or day minus 20. But now we've got a lot of healthcare providers out there with significant amount of time under their belt with very little clinical experience. They've just been doing what they've been doing, repeating the process over the years. And now we're bringing them back in and saying, we'd rather you not follow the cookbook. We're going to give you some information to try and have you make good differential diagnoses. And I tell you that comes with a cost. Some folks aren't interested in that. They would just as soon give the tan box and the pink box and the blue box when there's a code and not have to think through what's the patient's history, what's their comorbidities, what's their risk factors. And so it's a fine line right now for us trying to bridge that gap on telling people, you know what, you can feel free to think. You are authorized to make a differential diagnosis. You're treating based on some differential diagnoses, and not just you're not giving a differential diagnosis and you're just going to treat the patient's symptomology. It almost comes down to a more holistic approach to medicine and treating the whole patient as opposed to treating the one thing that comes out of their mouth that says, this is what bothers me, and starting that process so that you as an emergency room physician hopefully are tagging on to where we ended and are driving that care further, where I think historically you've gotten the patient and it's a start over kind of place that you're at.
Yeah, absolutely. I think there's, protocols are a safety blanket for us. Algorithms are very comforting, right? Because, if you follow them, you're not going to get in trouble. The question is that the best thing for your patient? Right. And the answer is sometimes no. And I've seen some really dramatic examples of people absolutely following the protocol to the letter. And it was exactly the wrong thing to do for that patient. I think an example that I've used before is an individual with who presented doctor's office lightheaded with a heart rate of 50. And, the paramedic said, I know what this is. This is symptomatic bradycardia. I'm going to pace this individual. I put the pacer pads on, zapped them, got to the hospital, and the doctor's like, what are you doing? Well, it's symptomatic bradycardia. Well, yeah, but the blood pressure is like 240 over 160. The problem is hypertensive emergency. It has nothing to do with bradycardia. And this is where the disconnect happens, right? That you don't eat the thought of what else could it be never enters the mind. It's just looking for a pattern and grabbing on the pattern that you're the most comfortable with and following it. And so why do people do that? They don't want to make wrong decisions for patients, but this also has to do with how we do quality improvement. And how is that generally done in EMS and a lot of systems? You take the protocol and you take the chart and you compare them. And if they match up, you get a thumbs up. Same is true for dispatch, right? You have your call taking script and you have the recording, and if they match up, great. It doesn't matter at all if you sent the wrong resources or you identified the wrong problem. And that's a mold that we have to break. We have to have actual quality improvement based upon the individual patient and whether or not we were successful in identifying what was going on and managing that individual.
Go ahead.
Hey, Doc, just a quick question for you. So you mentioned, in your article, and we've talked about it. So you said that, physicians basically go through a review process, and historically EMS providers get reprimanded, disciplined, or threatened. And so can you tell me what that looks like from a physician standpoint? So, put it kind of overlay it to what an EMS provider is. What would that look like from a physician, or from your history as a medical director? What would that look like when a provider made a poor clinical decision that had that affected patient outcome, and you were gonna review that with them? What are you looking for when you're walking into that review?
Sure. So let me back up a little bit, because this looks differently in different circumstances, but I want to lay a bit of groundwork about quality improvement. So when we think about new physicians, so we have a resident who's just graduated and they're a new emergency medicine physician. A lot of departments will, for their first year or 2 years, they'll do regular chart review because they want to see how that individual's doing. There may be some shadowing going on initially. And, there's that proactive approach to identify any patterns of issues. We see this done in law enforcement with new officers, with ride-alongs and check-off runs. Sometimes we see this in EMS, sometimes we don't. It's, you got your patch, great, here's the keys, good luck. But building on that, if there's a bad outcome or an error that's been identified on the physician side, what happens is that goes to a peer review committee. So generally, there's a group of physicians identified by the hospital, and it's generally a multidisciplinary group who review the case, and they review the individual medical records. They identify and do a root cause analysis of the issues. And, they go through the process of identifying individual decision-making errors and system errors. And I'll say it's quite unusual to not find system errors in addition to the potential human errors. And then there's, they bring the physician in, and there's a review of that case. And usually determination is made if it's a death, for instance, was this not preventable, potentially preventable, or preventable? And then there's a process of identifying what is going to happen to that physician. Oftentimes it involves education. Sometimes it's a specific curriculum or training that happens. Sometimes it has little to do with the physician and a lot to do with the system and the design of the system or the resources available. In those circumstances, the system issues are addressed. In some circumstances, this will result in referral to the medical board for a further review. And again, sometimes in those circumstances, they will specify a path for re-education.
Chief stole my thunder there because that's where I was heading, but I want to kind of follow up on that for a second. Do you think EMS should have a robust system such as you just described, maybe in the hospital setting? Is that what we need? Would that be useful in our setting?
Absolutely. There's got to be substantial investment in quality improvement. I'll say in Texas, we're very lucky because it is, the burden to litigate EMS or emergency medicine is very high. It's got to be, gross negligence to meet that burden. And so, in most circumstances, we don't see a lot of suits related to EMS and emergency medicine here. But that's not a get out of jail free card for us. That should increase our responsibility to ensure that even though we don't have as much threat of litigation, that we are doing all that we can to improve quality. And when we look at the errors in the hospital system, in emergency medicine, and we equate that to EMS, we're talking about the potential for hundreds of preventable deaths a year in Texas, which happen through EMS errors. That's something that we have to be responsible for. It's something that is essential for us if we really want this to be a real profession. If we want this to be seen as a key component of our healthcare system, and it is, we've got to be committed to quality.
I'm gonna coattail onto that, and then I'm gonna ask you both a question that I think you and we'll kind of toss it back and forth. But in the article, in the status section of the article, you mentioned trainees and residents, and you've done it again even here in the podcast today. My question is, does that and what you say is residents or trainees are expected to make errors, right? That there's an expectation that they're going to mess up. When does that expectation end, right? When do you no longer say, okay, you've been doing this, you've had the education, we've done quality improvement or control, we should no longer see that errors? When do you think that starts to transition over?
Well, really, it's, in residency training, it's graduated responsibility. So if I've got a new intern coming in, every patient they see, I'm going to be there with them while they're seeing that patient. As they move into second year and they, successfully complete that first year, then I may be with them on the more urgent patients. But if it's a low acuity patient, they're going to see the patient, they're going to present to me, and then I'll go see the patient and we'll have a discussion. They'll still be developing differential diagnoses. Sometimes they miss things. Sometimes I'll go see that patient myself and tell the resident, hey, you were completely off. They're not here for chest pain. They're here because they're depressed and they're suicidal. And so, well, how'd you know that? Because I talked and I listened and I paid attention. By third year, generally speaking, particularly second half of the third year, they should be relatively independent. So I'm there in the department. I may step in and monitor them managing critical patients, but they're relatively on their own. And it's not only to, how should I phrase this? They need to start having that sense of autonomy, and they need to identify their limitations and know when to reach out for help. That piece never ends. There's always going to be mistakes that happen. There's always the threat of errors, but you have to self-check. You have to know when you encounter something that you don't know how to manage, and you have to reach out for support. And that graduated responsibility is critical in developing that expertise. For residents, they've got faculty right there with them. So the threat of error is less because you have that direct oversight. EMS, unfortunately, in many circumstances, it's, you take a test on your protocols and you're handed the keys to the drug box. And you don't have that. Yes, you may have a EMS supervisor out there somewhere, but nobody ever wants to call them to ask for help. That's a culture that you have to build. Ideally, EMS should mirror what the rest of healthcare does and have that graduated responsibility over a much more extended time period than we currently have at EMS. Because you have to have that comfort. You have to have that sense that the leash is very short when you are new, and the leash gets longer and longer and longer, and until that you develop that expertise, not just the experience.
I couldn't agree more. And I want to say that I'm glad to hear this is not agency specific, but industry specific. But I can't say that I'm glad to hear that. But it is very much industry specific. And you wonder, is it because we have such a high turnover rate, right? At each agency, it's always, you can go to the next EMS service and get a job. So it's very difficult, especially if agency A wants me to be in a monitored state for a year or 2 years, and agency B gives me more money with less oversight. Well, then I might go do that, right? I kind of want to ask you both and see what you guys think of this. When would you say that clinical errors become a behavioral trend?
I'll start. I think that I got a couple of things when I wrote down is, when you have in your article, Doc, you said providers know what they don't know. And then they become talented clinicians when they can accept that they don't know something. That opens them up for the ability to be educated. And so for me, it becomes difficult when I have the employee that I want to be better. I want to give some information to so that they can make future sound clinical decisions in the area that they might have struggled in that was illuminated with QA or QI. And they don't want to know what they don't know. They're not interested in really knowing that. And that employee becomes focused on it's a system problem, which if it is, then that is absolutely the case. That's what we usually look at first. As you mentioned, we look at how did the system fail the employee who failed the patient. And then if it's not a system problem, and the employee doesn't want to know what they don't want to know, then it becomes difficult because it's more of a contentious interaction where the employee is deflecting or denying or honestly said, that's not how the patient presented, that's not what happened, and we have differences of opinions with the other healthcare providers that are treating the patient at the emergency department, who have a whole different take as you would have if we brought you that patient. So then it becomes somewhat difficult for the person to accept education, and that's a fine line right now, because the first person that you cause you make it become behavioral. That hits the street, and it's QA and QI are out to get you, and it's a behavioral. They're out if you don't do what they say, then you're going to have some serious problems. And unfortunately, given the current climate of trying to keep folks their personnel issues under cover and looking at more systemic issues with the organization, we don't get to defend the decision. It just goes out across the tribe as the training department's out to get you. And so that becomes difficult when it becomes behavioral. So I try and get buy-in from these folks, especially the senior members of the organization, the folks that have got the experience and have been around and have actually gone through probably too many changes. The next person comes in and changes this, and then somebody else comes in and changes that, and they're just almost neurotic about what's next to change. But certainly that's the difficulty for me, is when it becomes behavioral, when you repeat the behavior and you decide that you know better than the monitor, you know better than whatever that care plan is, and you don't have the clinical expertise or the background to go, I made this decision because this is what I had presented, and this is why I went in this direction, which in those circumstances, that's an easy education or re-education, because they already have some concepts. They just might have cross-contaminated them. But when we get the folks that just, I'm not interested in what you have to say, I'll sign your paper, and here we go again, that's difficult for an educational standpoint. We use coaching in those areas and just try and coach them to try and re-educate them to better serve the patient. And we try and bring in the final differential diagnosis and what happened with the patient at the hospital, almost as a wake-up call. Like here, you didn't call it a myocardial infarction. Your monitor said, STEMI, and when they got to the hospital, they didn't get STEMI care, and it was a STEMI. Their troponins were up, and they ended up in the cath lab 2 hours later. So here's where either we failed you, or you didn't recognize that the monitor actually was giving you some very good data. It's a fine line for me between when does it become behavioral issues and when is it education, especially stepping into an organization 9 months ago when everybody's wondering when the next shoe is going to drop.
Yeah, look, I think that there are a number of issues that create challenges. I think first is this perception that we expect perfection. And in some circumstances, as an industry, we sell that perspective that you should be perfect. And that's one of the things that in my introduction to new employees, I tell them, I don't expect you to be perfect. I expect you to want to be perfect. I expect you to aggressively pursue perfection, but know that you're never going to be there. And so having that understanding from the beginning that quality improvement is part of what we do, and that all of us, including myself, have made errors in the past. It's going to happen. The question is, can we identify our behaviors that lead to errors? Can we identify system issues that lead to errors and fix those so that we can minimize them? It is a challenge when folks will not step away from that perception of perfection, because it's hard for them to improve. And I've certainly had individuals in this system and other systems that came into me with that attitude. And sometimes it's a come to Jesus talk, because I can't work with that. I can't work with somebody who's not willing to admit that perhaps they were wrong, or they made a bad call. And what I found is that generally after those really one-on-one, lay it all out there discussions, that folks come around. And part of that's because over time they realize that you're not out to get them. You're out to make them better. You may be awesome. We're going to make you awesomer.
Yeah.
And that's a culture change. I'll tell you, in Austin, we have a union, and when I first got here, the union president, Tony Marquardt, one of his priorities was to insist that people undergoing a clinical review had representation from a union member. And of course, my staff was not real excited about that. It's a confidential process, and you really can't talk about it around other people. And I said, well, let's do it. We can make them part of the QI team, an ad hoc member of that committee. They can sign the same confidentiality agreement as everybody else does, and have the understanding that they are a silent observer to ensure that things are fair and open and transparent. And when we first started that, people wanted a union representation every time because they were scared, right? You get called in for a quality review, and people are pasty and sweaty, and their voice is shaking. But after a year or so, most people don't ask for a rep anymore, because they know it hasn't led to anybody getting fired. So that sense of insecurity has gone away. We still get some folks who will bring a representative in, but I think it's important to have an outside individual, while they can't talk about the case, at least validate that it's fair. And that's been successful for us.
One of my favorite quotes, and you do allude to it in your article, you just did again, is we don't expect perfection, but rather the passion to pursue it. I think that's what all of us in education, quality improvement, training, the administrative side of EMS, that's what we really want. We don't expect you to be perfect, but we want you to try to achieve that and continue to grow, as you said. Chief, what else you got? Because I've got one final question for Dr. Escott.
Yeah, I just have a comment. I think that we banter these words QA and QI around quite a bit. And I think quality assurance for me is us assuring that our system is set up well, that the providers have what they need, and we expose those areas where the system has let down the provider or the community we serve. I think the key is the word is quality improvement, which means it's an ongoing process. It means that we are identifying things that can be improved upon, or that we're using research and statistical data to drive that. And I don't think anywhere in our history we've ever used the word quality perfection, but I think that I know historically in EMS, that's just been an expectation. We expect you to be perfect, and when you're not, then we're going to come down on you. And that's led to a lot of other bad things, just, creative documentation in EPCRs and poor patient outcomes because we decided that we took the path of least resistance with a patient because we just weren't comfortable with the patient. It didn't fit our differential diagnosis, so we didn't really treat the patient, and it caused some. Or they just didn't want to. They didn't want it up in front of a QA QI board because it's just easier to just bring the patient to the hospital and not really meet their needs. So I think we've created our own monster in that area. But I think that for me, QA is a system. QI is we are constantly trying to improve each individual, and quality perfection is something that's just not attainable, though. I think the doc said it quite well, which is I just want you to be open to moving towards that, knowing that it's a bar that you're never going to jump over. And frankly, I think we need to stick with a culture and keep it going. We've changed our culture in EMS so many times and emphasized whatever the next hot topic is. And so I think that the culture change to and sticking with it, that we expect you to feel free to think. If we have questions, we're going to come to you and say, hey, what happened? I wasn't there. I didn't have the emotion of it. I'm looking at a very sterile run sheet, and I'm hearing a very sterile hospital report on what the patient outcome was. Can you give me some insight to what you were thinking and what you were presented with, so that we can, A, look at the system and make sure there's nothing that we can fix in the system, and B, that you'd be open to, did you think about these two pieces go together? And this third piece is part of that, and this was probably a better differential diagnosis, or more an alternate differential diagnosis before you got pigeonholed and ran with that. So I have one question for the doc. You're talking about a silent observer. Could that be a company? We don't have a union here at all, but we have, everybody in we have RBO groups, which are groups of employees and management that meet on a regular basis to address certain areas like training, FTO, equipment, and supplies. It's kind of a joint team of the management staff and the employee groups, so that everybody has a say at the table and nobody has more of a say than anyone else. Would that be something that might work with your silent observer, so that we can try to assure that you're not sitting in front of three people with multiple kazoo bugles on their shoulder and want to talk to you about something, but more so, this is where we want to go, and this is where what our goal is with you. I mean, anytime I sit down with someone, my first statement is, this is not punitive. Doesn't have anything to do with you being punished. It's about the call, and I just want to discuss this with you so that we can all come to an understanding of what happened. And it may be you did the greatest job in the world. But usually when they see that, they think, oh, I'm in big trouble. Here I go again. And that's my fault, and maybe EMS as well, where we don't give kudos to the good jobs. We just look for the jobs that need some improvement.
Yeah, I think it can be anybody, really. I think the key component is that if you're going to have an observer in, that it's somebody that the medic has chosen. Because you don't want it to create discomfort by having to have uncomfortable discussions in front of someone else. So someone who they feel safe with. I think if there's a circumstance where you have vocal opponents to these clinical meetings, I'd choose the person who's most vocal. And I think it's important to hear feedback. And certainly along the way, our union president came in and gave some feedback on how the process went, and could we consider doing this or that, and we incorporated that feedback. So I think it's good to have opposition there. This is how the dialogue improves. This is how the system improves. And I think you find, if you grab those most vocal opponents and engage them in the process, you find that it's really hard for them to be disagreeable, because they've been part of the evolution of the system. It's good.
Dr. Escott, I'm going to wrap it all up with one final question. So the title of this podcast is I'm Afraid of Being Fired. Again, this is our special Halloween edition, so thanks for joining us on that. So my final question is, if providers shouldn't be afraid of making clinical errors or clinical misjudgments, what should they be afraid of?
I think we should be afraid of making errors, not because we're getting, the threat of firing, but because of the threat of harming someone. I think that should be a powerful motivator. And certainly, having sat in countless reviews of individuals after errors, it's clear that the vast majority of the time that our medics are harder on themselves than we are on them. And it's, I think we have to give ourselves a break, and we have to know that, we've got to do the best that we can on the day in the given circumstances. And we should really not want to make errors, but we have to be open and honest when we do. I don't think employees should be afraid for any reason, other than, the concern that they're going to let themselves down and let the patients down.
Dr. Escott, thank you so much for joining us today. We're talking about the article, Talented Paramedics Shouldn't Be Fired for Making Mistakes in the GYMS EMS magazine. We will be linking that in the comment section of the podcast. Any closing thoughts, Chief?
No, I think that the doc hit it real well, that I think we're harder on ourselves than any organization. And sometimes it's not necessarily that I don't want to get in trouble, but I just don't want to personally know I hurt someone. And so I have to be able to get over that to ensure that the next time around I'm actually practicing medicine and I've gotten some information so that I can make adequate changes so that I can effectuate better changes and outcomes.
Dr. Escott, thank you so much for taking time out of your day. We know you're extremely busy, and we appreciate you joining us. You're welcome anytime.
Thanks, Doc, so much. We appreciate it.
You bet. It's been a pleasure. Y'all be safe.
Thanks, you too.